Hello everyone, and today we will be studying some lectures, and these lectures will be about mandibular fracture and management and oral surgery examination and also life support in ATLS. The ATLS we will discuss later, but for now let's study the facial trauma of mandibular fracture. And the facial trauma or mandibular fracture, the treatment of the mandibular fracture, of course, we have to treat it now. Treat the mandibular fracture is central component of facial trauma that the oral and maxillofacial surgeon must be adapted in managing. So the treatment of mandibular fractures is a central component of facial trauma that the oral and maxillofacial surgeon must be adapted to manage. Again, the treatment of mandibular fracture is a central component of facial trauma that the surgeon must solve. It is a central component of facial trauma. Okay, I will give you the information so that you can understand and you can carefully manage the mandible and fix it. The goal of a treatment, early return to function and anatomic reduction and stabilization, and preserving the occlusion and avoidance of infection, avoidance of malnutrition, malunion of or non-union of the mandible, and this will be unfortunate if we have a malunion of the mandible, and avoid infection, preserve the occlusion, anatomical reduction and stabilization, and early return to function. This will be the goal of treating and managing the mandibular fracture. The epidemiology of the fracture, there are more common causes, or the more common causes and epidemiology of the mandibular fracture are from motor vehicle accident, industrial and sport injuries, ballistic injuries, assaults, falls, and pathological fractures. Classification, allocation of the fracture. We have the symphysis and the parasymphysis and the body angle and ramus, the condyle and coronoid, and the dentino-alveolar. All are locations that could be a part of mandibular fracture. Again, symphysis, which is in the front of the chin, the body of the mandible, which is in the middle of the chin, the angle of the mandible is at the angle between the ramus and the body, and we have the ramus, which is at a little bit on the superior of the mandible, and the condyle and coronoid process, condyle behind and coronoid in front of the mandible. The fracture pattern, we have open fracture, compound and closed fracture, simple, communicated, green stick fracture, pathological, complex, multiple, atrophic, indirect, and impacted. All of these are types of and patterns of the fracture we will study now. Again, open and close, communicated, and green stick, pathologic and complex. Complex is like communicated, and multiple is like complicated and complex and multiple, and atrophic, indirect, and impacted. All of these are patterns of the fracture. Now, let us study after we have studied the patterns of fracture, let's study the biomechanics of fracture. We have a favorable fracture, biomechanical favorable fracture. The fracture line and the vector of the muscle pull. The fracture line and the vector of the muscle pull, keep the fracture buttressed and reduced and divided into two types. Again, buttressed and reduced. What keeps the fracture buttressed and reduced? The question and the answer is the vector of the muscle and the line of the fracture. Keep the bone buttressed and reduced. We have vertical and horizontal fracture, two types of favorable fracture. Unfavorable fracture, the fracture line and vector of muscle pull cause cause displacement and divided to also vertical and horizontal fracture. All of these are biomechanics of the fracture, favorable and unfavorable. There is the masseter muscle, of course, is the vector of the muscle, and medial pterygoid, lateral pterygoid, temporalis, all the parts that keep the muscle in favorable or unfavorable biomechanical place. Forces acting on the mandible, we have the tension, the compression, and the torsion. The tension, of course, it is downward, and the compression, which is compressing the bone, and of course the torsion, which is a force of torque. If we want to study more, we have to go to see the signs and symptoms of the fractures. All are causing pain, swelling, paresthesia, along distribution of the mental nerve, trismus, malocclusion, ecchymosis of the vestibule and floor of the mouth. Also gingival laceration. Radiographic examination, periapical examination or periapical view of the mandible, lateral oblique view of the mandible, left and right, and OPG, the most informative in diagnosis of mandibular fracture. What is the most favorable and important diagnostic X-ray in the mandibular fracture? The answer is OPG. Not lateral oblique of the mandible, left and right, no. Not the periapical, also no. Also we have the reverse Townes view and of the condyle fracture and the CT scan, axial, coronal, sagittal, and 3D scan. If we want to move on, we will discuss briefly the second, in an overview of the bone healing, we have a second bone healing. We haven't discussed the primary bone healing, but we will discuss it later. Second bone healing occur through process of remodeling, and callus formation occur in four stages. Again, bone healing secondary occur through process of remodeling and callus formation, and occur in 4 stages: inflammatory stage, cartilaginous stage, bony callus stage, and remodeling stage. Inflammatory stage, cartilaginous, bony callus, and remodeling stage. Primary bone healing is a process of remodeling of the bone by use of rigid fixation. This eliminates the need for intermediate callus and return to pre-injured stage. Treatment modalities, we have a closed treatment technique, maxillomandibular fixation, arch bar, which consists of arch bar, IMF screw, interdental wire fixation, and skeletal suspension wires. Also, we use the bonded and non-metallic tooth burn system, or all are from the maxillomandibular fixation. That are the closed treatment technique. Also, we have, and this is indicated in minimally and non-displaced favorable fracture, patient with sufficient teeth to provide stable occlusion, and comminuted mandible, also compromised soft tissue. All of these are indicated for close fracture. Close treatment technique. Maxillomandibular fixation. We fix the mandible and the maxilla together with the screws and wires. And this happens with compromised soft tissue and compromised mandible, and patient with sufficient teeth and minimal displacement and non-displaceable favorable fractures. This disadvantages for the close treatment technique is that the malocclusion and non-union also risk of infection and severe comminuted fracture. Severely comminuted fracture is not going to heal it. Also the risk of infection and malocclusion, malunion or non-union. Contraindication in multi-comminuted fracture. Non-compliant patient is not indicated for this treatment. Patient with alcoholism and seizure disorders and severe pulmonary dysfunction, also mental retardation and psychosis, also pregnant patient and patient with multiple system injuries. The external fixation, Rx of comminuted lumbar mandible, Rx of atrophic mandible, and when hardware infected. Their use limited nowadays after discovering rigid fixation. And the lingual splint is also useful in pediatric patients and partial edentulous patients. The disadvantage of lingual splint is it's used with pediatric and edentulous patients, but the lingual split, we have to know that it requires impression and casts. This one is the problem with lingual split. Open treatment technique. Advantage: eliminate the need for prolonged MMF and return early function and primary bone healing after use of rigid fixation. Primary bone healing after the use of rigid fixation. Note that there are 4 basic steps when using open reduction and internal fixation. There are 4 basic steps when using open reduction and internal fixation. What are these steps? Surgical approaches. Number 1, in surgical approach, we have transoral or transbuccal. Number 2, submandibular. And number 3, retromandibular. Internal fixation modalities, we have semi-rigid fixation that is uses mini plate and monocortical screws along lines of osteosynthesis described by Ciampi. This is the semi-rigid fixation. Internal fixation modalities uses mini plates and monocortical screws along lines of osteosynthesis described by Ciampi. Rigid fixation uses biocortical screws and rigid plates along inferior or posterior borders. Rigid fixation is different from semi-rigid fixation, and this both are internal fixation modalities. Rigid fixation uses biocortical screws and rigid plates along inferior or posterior borders. Note the lag screws are form of rigid fixation. Plates and screws can be divided into non-locking plate, locking plate, tapered locking screws, and threaded locking screws. All are type of screws: non-locking plate and locking plate and tapered locking screws and threaded locking screws. All our plate and screws can be divided into non-locking plate, locking plate and tapered locking screws, and threaded locking screws. Starting with non-locking screws and tapered and threaded locking screws. All have different shapes and they are used in the bone to fixate it. We have the lag screws, indication perpendicular fracture of anterior mandibular that provide stable buttressing. If we provide buttressing that is stable, we can use the lag screws, and this is used with the perpendicular fracture of anterior mandible. And of course, the anterior mandible is a U-shaped. The advantages of using these screws, they are cost-effective and regarded as one of the reliable methods of rigid fixation. Disadvantages is that they are not ideal for oblique fractures and cause displacement. Again, not ideal for oblique fractures and cause displacement. The potential injury to inferior alveolar nerve and tooth roots. Again, the potential injury to inferior alveolar nerves and tooth roots are not ideal for oblique fractures and cause displacement. These are the disadvantages. Not ideal for oblique fractures and cause displacement, and potential injury to inferior alveolar nerve and tooth roots. The transosseous wiring, infrequently used nowadays, but may be used in comminuted for arch alignment. What is the name of it? The transosseous wiring. It is used in comminuted number of arch alignment. Management of teeth in line of fracture, indication for removal of teeth in line of fracture. When we have a root fracture, pericoronal or periodontal infection, and presence of pathy and interference with fractured adduction. Complication and management. We do infection, non-union, nerve injury, and malocclusion. Again, infection, non-union, nerve injury, and malocclusion. These are all complications of the mandibular fracture. We finished this subject, and now we will move on to the next subject. The next subject is ATLS. Many people ask me, what is the meaning of ATLS? The ATLS means ATLS, Advanced Trauma Support, Advanced Trauma Life Support. Again, Advanced Trauma Life Support is the meaning of ATLS. Now, those people that asks me this question, they don't know what is the meaning of ATLS because they haven't studied it yet. I will give you some audio information. You will hear it and you will understand it, and you will be very good with it if you want to treat patients suffering from ATLS. What is the meaning of ATLS? Acute ATLS. You have to remember it. I will not say it now, so you have to remember it. I will say it now. Advanced Trauma Life Support. Again, Advanced Trauma Life Support. Preparation and transport. Of course, it's the beginning. After an accident, we do preparation and transport. Pre-hospital phase, airway maintenance. You have to make sure that the patient is breathing and control of external bleeding and shock. You have to control his external bleeding and shock control. Immobilization of the patient. You have to not move it. Control of the external bleeding. Communication with receiving hospital and immediate transport to the closest appropriate facility. After history taking, of course, including the events of the accident. Primary survey. What do we do in the primary survey? In the primary survey, we do the ATLS. What is the meaning of ATLS? Advanced Trauma Life Support. But in the primary survey, we do the ABCDE: airway, breathing, circulation, disability, and exposure. Airway with cervical spine control, breathing and ventilation, circulatory and hemorrhage control, disability, neurological status, and exposure of environmental control. Exposure and environmental control, disability, neurological status, circulatory and hemorrhage control, breathing and ventilation, airway with cervical spine control, breathing, circulation, disability, neurological status, exposure, environmental control. Airway maintenance with cervical spine control. What is the meaning of airway maintenance with cervical spine control? The meaning of the airway maintenance, of course, the first and the beginning and the primary survey, we do the airway maintenance with cervical spine control. The causes of upper airway obstruction may be bleeding from oral or facial structures. Again, bleeding from oral and facial structures. This is one cause of upper airway obstruction. Number one cause is bleeding from airway or oral facial structures. Number two, aspiration of foreign material, teeth or denture. Number three, facial fracture. Number four, airway structure trauma. Airway structure trauma and regurgitation of stomach contents. And commonly, the upper airway is obstructed by the position of the tongue, especially the conscious patients. Again, unconscious patients, commonly the upper airway is obstructed by the position of the tongue and the hematoma. I hope you understood what I have said. Let's continue now. The control of airway. How do we control the airway? First, we do a chin lift, jaw thrust, suction, oropharyngeal and nasopharyngeal airway, laryngeal mask airway, laryngeal tube airway, definitive airway, and surgical airway. Again, control of airway, we do the chin lift, jaw thrust, suction, oropharyngeal and nasopharyngeal airway, laryngeal mask airway, laryngeal tube airway, definitive airway, and surgical airway. First, we do the chin lift and suction. Then we do the jaw thrust and suction. By jaw thrust, we mean the holding the jaw. The definitive airway defined as inflated cuffed tube in the trachea. What is the definitive airway? Is the inflated cuffed tube in the trachea. Definitive airway defined as an inflated cuffed tube in the trachea. Number one type of inflated cuffed is orotracheal tube. Number two is the nasotracheal tube. Indication: unconscious patients, apnea, inability to maintain patient airway by other means, the need to protect the lower airway from blood and vomit, the need for mechanical ventilation, also important. Again, mechanical ventilation, need for protection of the airway from blood and vomit, and inability to maintain the patient's airway by the other means. This is the indication for using the orotracheal tube or nasotracheal tube. Unconsciousness, apnea, inability to maintain patient's airway, need for protecting the lower airway, and the need for mechanical ventilation. The surgical airway. What is the meaning of the surgical airway? Needle, circothyroidotomy, and it is immediate life-saving procedure. This is how to use it. You can pinch the neck with the surgical airway needle, circothyroidotomy. you have to use this needle to the neck and make an airway pass to the patient. Surgical cricothyroidotomy is a life-saving measure used with a needle. You have to know where is the thyroid cartilage, where is the cricothyroid cartilage membrane, and you have to know where is the cricoid cartilage. And from the cricoid cartilage, you make an incision from the needle, and you provide air to the patient. Cervical spine control with any patient sustaining injuries above the clavicle or with decreased levels of consciousness, one should assume there may be a cervical spine injury. Again, cervical spine injury. This is A, B, C. A, airway. B, breathing. C, cervical spine control. With cervical spine control, with any patient sustaining injuries above the cervical or with the decreased levels of consciousness, one should assume there may be a cervical spine injury. Avoid hyperextension or hyperflexation of the patient's neck. So don't extend his neck in order not to affect the cervix of his neck. Definitive cervical spine control requires immobilization of the neck, neural position, and semi-rigid cervical collar, head block, and tape over forehead and chin. All these are needed in cervical spine control. Also to protect and detect and suspect cervical spine immobilization. So please be careful with the neck and cervical spine. Breathing and ventilation. Of course, we have talked about A. It was the airway. This was the ATLS. ATLS meaning the advanced trauma life support. And A, B, C, D. C, circulation. We haven't talked about yet, but we talked about breathing. In breathing, we have to inspect the chest wall, that should be inspected for bruising and flail, chest, and bleeding. Also, the neck should be evaluated for evidence of tracheal deviation, subcutaneous emphasis, and distended jugular veins. Palpation. Chest should be palpated for the presence of rib or sternal fractures, subcutaneous emphysema, and wounds. This is used with palpation. Of course, the inspection does not have to be palpated. The inspection only about the neck also evaluates the evidence of forehead deviation, subcutaneous emphasis, and distended jugular veins. In the palpation, we do palpation to the chest, and that should be palpated for the presence of the rib or sternal fractures and subcutaneous emphysema and wounds. Palpation. Chest should be palpated for the presence of rib or sternal fractures and subcutaneous emphasis on the wounds. Again, and the last thing we do is the auscultation, a lack of abnormal breathing sounds. Circulation and hemorrhage. Of course, we have to maintain also the circulation. And this one is a type of primary control or a primary survey of the patient. Circulation, of course, I will talk to you about circulation. In circulation, we assess the shock and external bleeding and oculate breathing and estimate the blood loss and initial presentation of the patient and the signs and symptoms. Estimate the blood loss on initial presentation of patient and the signs of the symptom. What are the signs of the symptoms of estimating the presentation of the patient and the blood loss? The level of consciousness, respiratory rate, skin perfusion, pulse rate, blood pressure, urinary output, and mental status. These are all estimated for the blood loss and initial presentation of the patient and the signs and symptoms. The most common cause of shock in the traumatized patient is the hypervolemia. Is the common cause of shock, and that's caused by hemorrhage, either external or internal, into the body cavity. What causes shock? The most common cause of shock is in the traumatized patient is the hypervolemia caused by hemorrhage, either external or internal, into the body cavities. Inadequate tissue perfusion can cause irreversible damage to vital organs such as the brain or kidneys in a short time. Inadequate tissue perfusion can cause irreversible damage to vital organs. Inadequate tissue perfusion can cause irreversible damage to the vital organs such as the brain or kidney in a short time. Only the brain and kidney that this happens when there is inadequate tissue perfusion could cause irreversible damage to the vital organs. And the most common cause of shock in the traumatized patient is hypovolemia, and that's caused by hemorrhage, either externally or internally into the body cavities. Decreased intravascular volume second to blood loss lead to decreased pulse pressure and rapid pulse, diminished capillary refills, and cold clammy skin, and decreased urinary output. This happens when there is a decreased intravascular volume second to blood loss. That means after blood loss, the decrease of intravascular volume, this will cause rapid pulse, decreased pulse, diminished capillary refill, and decreased urinary output. This all happen in the context of shock. Other causes of shock is trauma and hypovolemia and damage to the vital organs. Let's move on. Management of hypervolemic shock. Two large bore intravascular lines, place 14 or 16 gauge, the out cubital fossa are the preferred tissue. Anterior cubital fossa. A blood specimen should be simultaneously obtained for cross-matching, typing, hematological, and chemical study. Resuscitation should consist of an initial bolus of 2 liter 20 milliliter per kilogram for pediatric patients of a balanced salt solution, 0.9% normal saline or Ringer's solution. Protect from hypothermia, 39 degrees warm IV fluids. This is only to protect him from hypothermia. This means we bring hot blood to the body. Urinary and gastric catheters unless contraindication. Again, urinary and gastric catheters unless contraindicated. So we do this all the time. Unless contraindicated, we do the urinary catheters. Direct pressure to the wound. Suturing scalp or skin wounds may best be managed with immediate closure with large monofilament sutures, packing, ligation, and splinting, casting, or fixation or fracture. Again, control of bleeding. Direct pressure to the wound, we have to control the bleeding by applying direct pressure to the wound and by suturing. Scalp or skin wounds may best be managed with immediate closure with large monofilament sutures. This is only on the scalp or skin wounds, and this is to control the bleeding. We use packing and ligation and splinting, casting or fixation of the fracture. Of course, there are many pictures to show you how we can fix the fracture and fix the bleeding and control it, but you can imagine in your head how this will happen. Disability, neurological status, this is on D, ABC. D, disability. Neurological status, disability assessment by AVPU method. A, alert or obeys commands. V, response to vertical stimulus, to vocal stimulus. P, response to pain, and U, are responsiveness. And also we have a neurological assessment, which consists of GCS scale and pupil reaction to light and limb movement. AVPU and neurological assessment. Alert, vocal pain and unresponsiveness. GCS scale, pulp retraction, reaction to light and limb movement. We have a Glasgow Coma scale, GCS, and then we have pupil reaction to light and the limb movement. Let's start with Glasgow GCS, Glasgow Coma scale. Glasgow Coma scale, we have to determine the eye response and verbal response and motor response. Starting with the eye response from 1 to 4 and verbal response from 1 to 5 and motor response from 1 to 6. We combine those responses and we have a severe injury, moderate injury and mild injury. Mild injury, if we have 15, 13 or 14. Mild injury, 9 to 12 is moderate and 3 to 8 is severe injury. Of course, we do the eye opening. If the eye is not open, we give him a 1. If the eye open in response to pain, we give him 2. Eye open to speech, 3, and eye open spontaneously, 4. Next to the verbal, 1 is no verbal, 2 incomprehensive sounds, and 3 inappropriate words, then 4 confused, and 5 oriented. When we go to the motor, number 1, no motor response, number 2, extension to pain, number 3, fixation to response to pain, and number 4, withdrawal from pain, number 5, localized pain, and number 5, obeys commands. And this Glasgow scale, we give it from 15, 13, 14, 9, 12, and 3 to 8. E, exposure plus environmental control. The patient, ABCDE, after D, disability, we choose D. We choose E, exposure. The E, exposure, the patient should be completely disrobed so that all of the body can be visualized, palpated, and examined for injuries or bleeding sites. The clothes must be completely removed. The patient must be quickly covered with warming blankets. Use of a patient warming system. Then use of fluid warmers and increase room temperature. Secondary survey does not begin until the primary survey is complete. The secondary survey is not the ABCDE because it is different. The resuscitative effects are established and the patient is demonstrating Normalization of the vital fracture functions includes subjective assessment, AMPLA, and AMPLE history, objective assessment, inspection, palpation, percussion, auscultation of the patient from head to toe. Ample history. What is the ample history? That is allergy, medication, past medical history, last meal, and event, environmental related to history, to injury, environment related to injury. Of course, we have studied such thing from the ample, cause the AVPU alert, V vocal, and P pain, and U unresponsiveness. And then we have studied Glasgow, and now we will study secondary survey, the ample, allergy, medication, etc. Skull fracture, cranial vault or base of the skull. We can see the classic signs of skull base fracture, retroauricular ecchymosis, bottle signs, and the CSF leakage. We also have to assess it, cranial nerve 7 and nerve 8 may be affected, and cranial arteries may be affected. Pupillary light reflection also, we can detect it from dilation and constriction, size and shape of the pupil. Comprehensive treatment injuries, forehead stabilization necessary, and rehabilitation and stabilization of appropriate transfer. This is the definitive care, of course. Comprehensive treatment of all injuries, fracture stabilization necessary, obturation intervention, if operative intervention is needed, intensive care, rehabilitation, stabilization of appropriate transfer. And let's go to the next subject now. We have finished this. Next subject is about the examination of the patient. History taking, full name, age, chief complaint, history presentation of the patient, date of onset of the pain, duration, area of which the pain radiates, lethargy, malaise, fever, chills, ulcer, swelling, long lesion being present, whether it's getting larger, or a medical history, surgeries, medical surgeries, genitoury pain, burning pain, and cardiovascular, respiratory, sputum, wheezing of the patient with complicated medical histories is present, and endocrine assessment, rash, itching. We do family history, we do clinical examination, site of compliance. A general examination is also being assessed for the patient. Diagnostic tools are observation, palpation, percussion, looking, inspection, touching, smelling, and tapping, listening. Observation also, we have to observe skin color and texture, whether it's pale, flushed, with the jaundice or with no jaundice, dry or sweaty. Head, face, nose, neck, all should be examined for size of thyroid gland from the neck, teeth also from the mouth, and asymmetry from the eye, and the ear is the sound and the head is the sharp asymmetry. Palpation is also used, temporomandibular jaws, percussion, auscultation, neck injuries, and investigation. We do the mean corpuscular hemorrhagical concentration, MCHCS. This is a blood test that should be 32%. Life function, X-ray, chests, and bone diagnostic. Family responsibility and work and history. We do the scissors. We have to use scissors, we have to use curettage, we have to use swabs. Operative under general anesthesia also must be done to the patient. The retractor, scissors, curettes, are all important. Complex operations require additional sets of instruments. Let's move to the next subject, mandibular fracture. In mandibular fracture, we know that the mandible can be fractured. There is, according to type of fracture, according to site, we can classify fracture according to the cause, according to displacement. Mandibular fracture the mandible represents 1/3 of the face, and the most research gives the indication of number of fracture. We have the simple, according to the number of fracture, that no displacement, not connected to the outside environment. Compound fractures connected to the outside environment due to the fact that the connection to the PDR management of the ligaments. Comminuted fracture, which is caused by more severe trauma, resulting in severe lines or connected to each other, resulting in divided of the bone into several pieces. Pathological fracture, simple compound. On the symphysis, and there are many pictures you can search on Google, fracture flap, on how to treat the fracture. According to the causative, we have causative force, unilateral force, and bilateral force. We have multiple force and comminuted force. Pattern of fracture, of course, there is many patterns of surgical anatomy. You have to study it very carefully. Muscular attachment and displacement and the large of the mandible to thickness and according to the placement line. Unfavorable forces or unfavorable fracture when the muscle pulls distract the fragments away from each other, and this is unfavorable fracture. Favorable fracture when the muscle pull resists the displacement of fracture fragments, then the fracture line is considered favorable. There is horizontal favorable, horizontal unfavorable, and there is vertical unfavorable and vertical favorable. The horizontal unfavorable fracture can be seen, and you can imagine it, how the fracture will be affected. Symphysis region, this region is controlled by mylohyoid, genohyoid muscles, the line of the mandible and the oblique number, the bilateral of symphysis regions. Unconscious patient may result in backward displacement of similar regions of region and genohyoid. Condyle is also affected. Let me take I will give you a rest of 5 seconds. Please take it and use it carefully. Okay, the rest is on. Condyle. The condyle is affected by lateral tri-MS, and this may result in medial and inward displacement of the condyle. Fracture of the ramus is usually sandwiched. Fracture of the ramus is usually sandwiched between masseter and mid PTE and the mic, possibility for displacement of this label. In edentulous patients, a result of teeth extraction or resorption of alveolar bone, or for these reasons, the mylohyoid will be relatively speaking higher in position than when the teeth are present. This may weaken the jaw. A trauma applied to the mandibular usually caused bilateral of symphysis paroxysmal with crowded downward displacement. Clinical presentation, symptoms and signs of mandibular fracture: pain, especially in taking and swelling, also swelling, bruising, bleeding, and rolling, all happening and loosening of the tooth. Deviation of the mandible, gagging of posterior teeth on the ipsilateral teeth or side open bite on contralateral, and there is a pain, limitation in jaw movement and tender to palpation with crepitation sound in certain cases may be heard or felt. Thank you for listening to this lecture. Again, I will give you only one information about this lecture. So what did we mean when we said can be heard or felt? There is pain, limitation in jaw movement. This is on temporal mandibular. Certain cause may be heard or felt. Gagging, deviation of the midline, all are causes by the mandible. Drooling, altered bite, mobility, all are